Okay, thank you guys for introducing yourselves. I am Cindy Amilcar. I am emergency medicine faculty. I'm also their Med Ed Fellow this year at McGovern Medical School. I'm at UT Health here in Houston, Texas. And so I want to talk to you guys about my rare procedures escape room. So by a show of hands, how many of you guys have done an escape room before? Good. So a good number of you guys. Okay. So for those of you who have not, what is an escape room, right? So essentially an escape room, what happens is they trap a whole bunch of people in a room for a specific amount of time with the sole purpose of solving a puzzle to try to escape the room, right? This started in 2007 in Japan. And then it became a medical educational tool in 2014. And since then, it has been very popular and spread like wildfire. But why? Why would an escape room be an appropriate medical tool, right? Why would we use this as a tool to teach? And I think the answer is simple. Learning is not a spectator sport. So for many, many years, we would sit in lecture and we would be spoken to by a teacher, and that would be how we would learn. We have now shifted from being a teacher-centered instruction to a more learner-centered instruction. And so now we have encouraged our learners to take control of their education, right? And I think that's why the escape room is really popular, is because now you're asking your players to try to solve puzzles, and the teacher is not doing all the talking per se. The other reason I love escape rooms is because it's a very low pressure environment, right? You can teach or review topics that are very high yield, but it's very low pressure and chill. This is supposed to be a game. It's supposed to be fun and engaging. So who did I make this escape room for? I made this escape room for emergency medicine residents, years 1 through 3 or 1 through 4. It just depends on what institution you're at. My current institution is a 3-year. However, I trained at a 4-year. And so the goal is that the more senior residents would kind of help the more junior residents solve these puzzles, and they'd work as a group to try to escape the room. The what, in my case, is rare procedures. So as an emergency medicine doctor, there are a slew of procedures that I'm qualified to perform, right? But there are some that you can go throughout your entire 3 or 4 years of residency and you won't ever see or do. 2 of those procedures are an emergency thoracotomy and a perimortem C-section. They are just as scary as they sound. When you see them done in person, they can be a little traumatizing, especially to the patient whose body you have to kind of crack open And so I wanted to create a space where we can review these topics in a very low pressure environment. So when they do go out to practice, although they may not have done one, they have the tools to do it and they feel confident to do these skills. The where is this is done in conference. So every Thursday we have conference in residency, and this is supposed to be done in person. Now it can be done online through Zoom or WebEx, but if I'm being honest, it's just not as fun, right? Being trapped in a room with your friends and your colleagues, being able to really work as a team in person is a lot better. So the intent is in person. And the when is before their in-training exam. So the in-training exam, it happens every single year, and it's in preparation for their board exam, which is their state exam. And this is really meant to be a review. So these residents have already either learned this topic through lectures or conference or bedside teaching. And this is meant to just go over it, right? It's not meant to teach them right now how to do these specific procedures. So the way the day starts off is all the residents meet in one large room, and we kind of go over the objectives, the background story of the escape room, and the rules. And so on this slide here, I have 3 objectives. One of them is to calculate the Glasgow Coma Scale, which is GCS, based on the clinical exam. The other is to recognize when to perform an emergency thoracotomy. And lastly, identify correct steps to perform a resuscitative hysterotomy, AKA a perimortem C-section. The last two are the rare procedures. The first objective is actually not a procedure. It's just something that we do with every trauma patient, and it's not rare. We have to calculate this scale with every single trauma patient. The reason I included it here is because I realized the residents struggle. They really struggle trying to do this scale in their head. I mean, oftentimes either myself or the trauma I'm attending is like, what's the GCS, guys? What's the GCS? I haven't heard anyone count it out. So essentially what this is, it's a scale that we use to rate the level of consciousness. So if a patient comes in and they're barely conscious or they're moaning or not really moving, that kind of tells us what we need to do next. Maybe I need to intubate. Maybe I need to secure their airway before I do anything else. So it's part of our primary survey. It's the first thing we do, and it's very important. So that's why I included it here, although it's not a rare procedure. Okay. So here's the background, right? So a building collapsed. It has injured a lot of people. Your hospital is gearing up for a mass casualty. The charge nurse says she roomed 3 patients for you to evaluate and treat. You have to find the key to escape the room, but you have to solve these 3 cases in order to find the key. You have half an hour to escape this room. And the rules, again, you have half an hour. There are no devices. And so the residents are going in just with their brain and their prior knowledge. There's no laptops, there's no iPhones, there's no iPads, there's nothing. It's you and your colleagues, and you're working as a team. If for any reason you need to leave the room, you need to go to the bathroom, you're feeling overwhelmed, you just need some air, that's perfectly fine. But your teammates are going to continue playing and the clock will not stop. Do not force anything open. If something is meant to open, it will open. If you solve the case properly, it will open. So don't try to squeeze anything open or break anything open. Now, this might seem a little bit harsh, but if you receive any hints from your faculty, you get 1 point added on to your time, and that's for every hint. The reason is because this is really meant to be not about the instructor. This is really meant to be about you residents working as a team and talking amongst each other to try to solve this. The cases aren't necessarily hard. And so I really wanted the instructor to just be a fly on the wall. I mean, they can give you hints, but they will not give you the answer, okay? And then lastly, you will be notified when you have 10 minutes left. So most importantly, have fun, work as a team. You know, this is supposed to be engaging and interactive, and the team with the lowest time wins. When I played this game when I was a resident, we won a gift card to Starbucks. The other time we won a gift card to a movie. And so that really got all the residents hyped up because we're poor. We have no money. So you tell us I get a gift card to Starbucks and I'm ready to play, right? So without further ado, I'm going to walk you guys through the escape room. Now, I just want to reemphasize, this was made for emergency medicine residents. So it's going to be a little hard to play in this setting because you guys don't have the prior knowledge, but I'll walk you through how it's supposed to be played. Okay, so we're going to dive in. So this is an example of how the room can be set up. You have 3 stations. One's the balloon station, one's the locked box, and then one's the card station. So we're going to start with station 1. All right. You have an 85-year-old male. He's found under a pile of rubble and the patient is altered. A, he's moaning. That means his A is for airway. He's moaning. B is for breathing. His breath sounds are clear. C is for circulation. That's his blood pressure and he has really cold extremities. And D is kind of like your neuro exam, right? So he opens his eyes to pain. He's posturing as well. And you're asked to calculate the GCS. On the sheet of paper that's at the desk, at station 1, it says, pop the balloon with the corresponding GCS to reveal your next assignment. What the residents don't know at this point is that the balloon with the correct scale value, that has their next patient inside of it, okay? We have hidden case 2 inside of the balloon. They cannot move on to station 2 unless they pop the correct balloon. So you guys might be asking, well, what's stopping them from just popping all the balloons and moving on? Well, what's stopping them is that for every balloon that you pop that's incorrect, I add 20 seconds onto your time. So you could easily just pop all the balloons, but be mindful, the team with the lowest time wins, right? And this is supposed to be for you to like really learn and try to calculate a GCS. So because you guys don't have the prior knowledge of how to calculate a GCS, I'm going to show you a different way to play this game. And then later we can go on how to actually calculate it. So one way, because this is supposed to be played in person, one way to play it online is to play hangman, right? So it's the same case. You have your clinical exam here at the bottom. The residents have the same task. Instead of popping a balloon, they're going to tell me, the instructor on the other side of the computer, what they think the GCS value is. So for example, let's say they tell me, oh, I think it's 12. 12 is incorrect. I pop a balloon. You have now 5 more chances in order to get this right. Let's say they say it's 3. 3 is incorrect. I pop a balloon. Okay. The correct answer in this case is 7. All right. So in real life, you'd pop the balloon and the balloon would, case 2 would float out of the balloon. I can't float out of the balloon in the screen, so it just kind of floats down on the screen here. And they would move on to station 2, where they would complete this case. So this case is a 55-year-old male who loses pulses, meaning he goes into cardiac arrest while you're doing your primary survey. So while you're trying to calculate your GCS and you're doing your exam, he loses pulses. The task at this station to select all the indications to perform an emergency thoracotomy. Once you've done that, arrange them in numerical order to reveal a combination. So of the 5 choices listed here, I'm going to lower this. Of the 5 choices listed here, these 3 are correct. So 1, 2, and 5. So the combination to this locked box would be 1, 2, and 5. One of the reasons I love escape rooms is because it has immediate feedback. If you enter combination 2, 3, and 4, it'd be wrong. I, as the instructor, I don't have to tell you it's wrong, but the box just won't open, right? So you now have to go back to the drawing board, speak with your teammates, and try to figure out which three cases are actually right. So once you get the box open, case 3 is inside that box, and then you'd move on to station 2. So yes.
Can you hear me? So maybe for case 3, because you got some bright people in this room. So maybe for case 3, you let them talk it out.
Okay.
And come it up. Because yeah, we don't gotta pimp people out, but we could give them an opportunity to discuss it. So and then you act like the facilitator, just to keep that interactive portion here.
Okay. Sounds good. So case 3, you have, this might be the hardest case. This case 3, you have a 34-year-old pregnant female who's endorsing abdominal pain. During her primary survey, again, she loses pulses and you guys start CPR. So what the residents would see in person, the task first is to choose the right notes, okay, that have the correct statement on them, and then arrange them in order in which you would perform a hysterotomy, okay? So what the residents would see... It's okay. So what the residents would see in front of them on the table is they'd have a table with a whole bunch of sticky notes that have phrases or statements on them. Their job is to choose the correct statements and then line them up in the order in which they would perform this procedure. So let's just go through all these statements, okay? So confirm the uterus is at the umbilicus. This just means when you feel her belly, you can palpate her uterus and it's up to the umbilicus, okay? Leave placenta in to aid maternal oxygenation. Make a vertical incision through the uterus. Make a horizontal incision across her lower abdomen. Deliver baby and placenta, pack the uterus and the abdomen, meaning pack with gauze, make horizontal incision through the uterus, and make a vertical incision through the xiphoid, which is right here, starts right here, and then down to your pubic symphysis. So down to right below where you would think her bladder is almost. Okay. So I'm gonna let you guys talk amongst yourselves to see which statements are correct, and then we'll try to arrange them in chronological order.
One of the GCS questions.
Okay, you know what? Let's go back to the GCS. I mean, I already told you the answer, so we can't go back to the GCS, but let's try this one. You guys are funny.
Estimate says we deliver the baby first. We just took a repo test yesterday, so we know.
So you can.
Well, how do you deliver the
Yeah, I
baby?
think you can.
And then
You want to deliver baby first?
No, they were joking. They were joking.
Oh, okay.
They're gonna speak out loud so you can hear it. Go ahead.
Just C-section?
Yeah, so like you would confirm where the uterine fundus is, I would hope, and then I think after that, then make horizontal incision through the. Oh wait, no, where's the abdomen first? Yeah, the yellow one, horizontal incision across the lower abdomen.
Okay.
Then you have to go further, so I don't know where the
Would you
muscles are.
vertical after that?
Then, but not.
Would you vertical from xiphoid to pubic
Xiphoid to
horizontal?
pubic That feels like a lot,
I think you.
but is that
When you deliver it and then pack it?
I was thinking pack last.
packet last?
I would say
Leave placenta
last.
in.
Oh, these are all options.
Good, we
Yes.
put these in order, correct?
Yes, so you have to choose which ones are correct and then put them in order.
Okay,
So
perfect.
all
Yeah,
nine
they're not all
are
correct.
Can we know how many are correct?
That would be a hint. So there are, I think there are 5 that are correct.
Can we see the
5 that are correct.
So there's 5. You can't say you think. You know that 5.
There are 5 correct. I had to count them.
Okay.
There are 5.
It didn't take 20 seconds.
What do you guys think about like the pink, green, yellow, and yellow, orange?
She just snapped, so I think she has.
No, indeed.
So say them out. Say them
You're saying pink,
Like
green,
confirm the uterine fundus is at the umbilicus.
Okay.
Make a horizontal incision across the lower abdomen.
Okay.
Make a vertical incision through the uterus.
Okay.
Deliver the baby and the placenta, and then pack the uterus. And the
You guys were very close.
Oh.
Wait a minute. That wasn't. Maybe they were still discussing it.
I'm sorry, guys.
Okay.
So you think
I'm
they
going to give you a
are-
little bit more time. And then when you're ready, tell me that's your final answer.
So,
Jeopardy.
who wants to give a edit?
Well, probably just want to talk. So maybe instead of a vertical incision through the uterus, you get horizontal. Or not?
What do you guys think?
Because if you're cutting
That
horizontal.
makes sense. That makes sense.
Horizontal.
not that we just went through reborn.
That's a good point.
Because if you so like that, you don't want to cut
Again,
vertically
right.
within that horizontal. So like you want to cut forward.
Yeah, that makes sense.
Yeah,
So like create another layer of the same thing.
that sounds good to me.
Yeah, exactly.
You guys have any other?
I like that one. You wanted to get into that?
Sure. So we're going to go. Is that final answer, guys?
I like it.
Do you have a?
Say it out. It's here.
And then if
So
you're
we're
fine.
going with from the computer on this
Mhm.
at focus, and then we're making a horizontal incision across the lower abdomen, followed by another horizontal incision through the uterus, and then we're going to deliver the baby in the placenta and pack uterus out.
And that's your final answer.
Now.
I'm going to give you a hint that won't cost you any time. You guys were closer the first time.
Sorry, guys. All right, so leaving the
You were closer the first time, and only one of those choices was incorrect. So out of the 5, only one of them was wrong.
So if we were closer,
So which one of you were wrong? There's two sections, it's horizontal, right?
This is a C-section.
This is a
I mean,
hysterectomy.
Yeah, that's. So
Yeah,
it'd be
you need
horizontal.
the baby,
Do you read the
the
baby?
placenta,
Are we not going there?
Is the baby dead?
Oh, just
I think,
Baby's dead, right?
no, the mom.
Oh.
You're only doing this to rescue the baby.
And
Oh,
then
to rescue
So
the
you
baby.
might be,
Oh,
you might
sorry.
be,
So we're
so
not
part of it is you might still be trying to resuscitate the mom concurrently. I'm just discussing this since I'm not sure of the correct answer.
Can we
So
go back to
the
the
mother-
scenario and repeat it? Will you
Please.
read the scenario?
Read the scenario again.
Okay. Let's go back here.
Oh, what's the answer?
A 34-year-old pregnant female endorses severe abdominal pain, right? During your primary survey, she loses pulses and you start CPR. So you have to select the right notes and arrange them in order to perform a resuscitative hysterotomy, which is also known as a perimortem C-section.
So we're trying to say the mother.
Okay.
Okay. Both.
Mother is almost done.
That's what.
So I would think that the maternal oxygenation.
For the baby to
Right.
survive.
Right, I was like, that.
Maybe because if you deliver the placenta, you might induce more bleeding if she's like you're
Yes.
atopic.
Right.
I love that thought.
Yeah, I like leaving in the placenta instead of the
Did you guys hear what Nicholas said?
As opposed to, so what are we switching it up?
Okay, well, why is she having severe abdominal pain?
chicken food out.
Why does she have acute abdomen?
The baby? Would be like-
Why is
Oh,
she bleeding?
placenta.
Yeah.
Placenta.
The eruption.
Yeah.
So then, is that the case you want to remove the? Oh, so I create really aggravated.
Yeah.
Oh, that was scary.
I can eat this right now.
So what do we know for sure is correct, right? We're starting with the pink.
Yeah.
We are assuming the next step would be to make a horizontal incision, level one.
And then it's a vertical incision, right? Because that's what we messed up. That's what we
Maybe.
miscorrected
Okay.
last
But
time.
there was one thing incorrect the
Yeah.
first time.
So maybe it wasn't that, it was
The
something else.
vertical could have been fixed.
Yeah, I think maybe I'm not a physician or physician to be. Wouldn't you give some oxygen so the baby survives until the baby is taken out? Because the mother doesn't have any pulse and not pumping oxygen to the placenta.
So-
I don't know.
So do you think that we should?
These are very good discussions, guys, by the way, like very good discussions.
I'm thinking about it. the placenta.
Decrease SVR.
Right, if you have, right, like left circulation factor.
Oh, that's fair.
Don't you want it?
But you might. It's like, what
Yeah, if
like
she's
atopic
having-
and not having tract uterus.
Wow.
I had it too, I forgot.
I feel the hemorrhage more.
Yeah. Oh, you
So
want
you're
to
saying you would take it out or would you want
Keep it in.
you're gonna,
It's opportunity for sepsis,
Right.
opportunity for hemorrhage,
right,
and the patient shock or
it's like.
pulses are, I think.
What's our hunter students?
Really? Sticking your medicine. I don't know if it's wrong, like, is it leave the placenta in or is it make a different incision? Is it the vertical?
We're definitely like.
Okay.
Definitely.
So why don't you guys tell me the 4 that you feel confident are definitely correct?
Can I just ask a question? Like, what?
Of course.
Hysterectomy?
What'd you say?
Hysterotomy, what is that? Can we ask that? Or,
So it's essentially opening up the uterus to remove a baby.
Yeah, so I think that we could all agree that the first step is correct, right?
Yeah.
Okay, you want to confirm? Okay.
You can confirm that with you.
You're like, confirm, final answer.
yellow.
We agree on that horizontal incision across the lower abdomen. This seems- Yeah. The next, because the first time we said this, the vertical incision from,
Through uterus.
yeah, through uterus.
And then we also said
That was-
vertical, horizontal, right? So is it then vertical from the side plate?
Or you, I think one of those is wrong, and half is correct and the other is correct. It's the,
Yeah.
after yellow to orange, what are we? Yellow.
I think half is correct. Because you
Yeah,
want to try
right?
something.
Right, and of course, deliver the baby.
I do.
But if you're saying liver, baby, and placenta, then you also can't say placenta.
Yeah.
Right?
Yeah.
Which means it's not the blue.
Yeah.
So it's probably will make the word position.
But if you're resuscitating someone, I assume you're gonna give oxygen. So,
But how, so leaving placenta in oxygen seems like a stretch.
yeah.
It seems like we're,
Okay.
right?
I feel like the placenta for oxygen would be helpful for the baby.
Yeah.
That's
Yeah.
what I'm
Right.
So I don't know that it's
if
leading
the
them
I
to,
agree.
Right,
right?
so
But
our final answer then is pink. Upper pink, upper right yellow.
Do we think because it's a traumatic experience? Do you think because it's a traumatic experience, you want to do a vertical cut besides going to the surfaces to peel
No,
open?
when we say blue, and then we changed to green, Cindy told us that we were wronger.
No, we.
So, okay, so correct me if I'm wrong. The first time you guys gave me your 5, it was confirm, make a horizontal incision, right?
Yeah.
And then make a vertical through the uterus, and then take out baby and pack.
Yeah.
Right. So of those 5, only one of them was incorrect. You guys never chose this blue.
Right, yeah.
Right. So out of the 5, only one of those is incorrect.
I mean, the first one's for sure, right? And then the second one we agreed on. The third one we miscorrected. We have to deliver the baby. So we're packed uterus, you know?
I think the
I think
blue
it's-
bottom
and
one,
then-
like you said,
Should we
because
switch out?
it's like, we're performing like a nice C-section right now. If you do this like horizontal one.
Yeah,
And then
yeah, yeah.
another, so like if it's a traumatic situation, you're like,
Yeah,
essentially, right, like all the way down and then take the baby out as fast as
Yeah.
possible.
That's true.
So I think what you're saying makes sense to me, but what do you guys think?
Yeah.
I don't know.
She's smiling, so I think you got
Because it's emergency.
Right, right.
Yeah.
Big cut.
it.
Yeah, but
You want to do it as
wanna
quick
get
as
the
possible.
baby.
Yeah, that's fair.
So you're saying that instead of- as opposed to horizontal.
As opposed to.
I'm not sure. I would look it up.
Oh, you're saying.
Yeah, because I'm thinking it has to be vertical.
A nice-
Horizontal.
It can't be the
That was
same.
my thought process. So that's. Horizontal.
Yeah.
Okay,
I
yeah,
agree with you that they should both should be in the same direction.
exactly. Yeah. So,
Well,
We-
give more.
physically, you cannot open space as much if you find
The same, that's right.
yeah, position. You cannot take the baby out. You need to open like a potato, a baked potato, squish it and open it both ways.
Yeah.
I mean, only to-
Yeah.
yeah.
I think opening like a book. Like a morbid way. Okay, so we cut.
so wait,
So we're gonna-
just like ask, so what are we prioritizing here? Like the life of the baby or the life of the mother?
Oh.
Well, we don't know who's the most stable, right?
I mean,
Yeah.
she's going to have the big
Scar.
scars, but she may survive and the baby may
Will survive,
survive.
Right.
Yeah.
I
I think it's the.
I'm thinking like simultaneously,
right.
if like the mother is like shocking, and she- but
Uh.
that would, the big vertical incision would be conducive to find where that belongs, but I think, you
That's a good point,
know what I'm
right?
saying?
Because then you can find where.
Yeah.
there's a
Right,
bleed or where
exactly,
there's-
yeah, explore, so it's like its own.
During death, I'm sorry.
Yeah. You guys wanna lock that one in? Alright. Confirm, alright, you ready? Alright, confirm the theater of uteruses at umbilicus, and then we're gonna make the vertical incision from xiphoid to pubic symphysis. And then we're gonna make another vertical incision through the uterus, deliver the
You
baby.
can't do 2 verticals.
Oh, wasn't that? No, it was
Yeah,
yellow. Big horizontal incision across lower abdomen.
And then the second one.
thought we
So like pink, yellow, blue, yellow, orange, right?
Xiphoid
Is that what
before
you're saying?
abdomen?
No,
Make this abdomen before the xiphoid
abdomen, then the
cut.
lower blue
You're
one.
making like a cross.
Cut here.
Oh, wait, sorry,
We
sorry.
gotta cut, like,
Ignore what I just said.
You're cutting through skin and then we're cutting through the uterus. So the question is like, are we cutting horizontal across the abdomen or are we cutting vertical across the abdomen?
Right.
And then what are we cutting
For
for
the
the uterus?
uterus,
So
yeah.
we're gonna do blue, right? And then we're gonna do either vertical or horizontal, but because they're already doing vertical, we should probably do horizontal.
Remember only one was wrong.
Which one's on? We
The
did choose?
one that we think was right before was.
Oh, yeah.
No, she didn't tell us.
She didn't tell us, that's what I thought.
So that's being vertical and vertical.
Does that not make sense?
So would you do?
Yeah,
We can just keep, we can keep shooting in the dark. But one time, right, you know?
Yeah.
How many balloons?
So which ones do you think is wrong, or do you don't know? Because there's only one
I
wrong.
think the blue make vertical incision from xiphoid to the symphysis first, and then a horizontal in the uterus. So we were trying to talk about two different cuts, right?
Remember,
For the first time-
remember the ones that you chose the first time and only change one, because right now you're changing two.
Yeah. So yeah, we just changed the shape.
Wait, what?
So yeah.
Yeah, I think you switched the lower abdomen for the xiphoid.
Oh.
That
Oh,
makes sense.
Lord. That's too
Vertical.
Yeah, which I
vertical.
think makes sense, because vertical cut here, and on the inside, vertical cut.
Yeah.
But yeah,
Oh,
Doc,
yeah,
I don't think you can, yeah, I don't think it would be too vertical. I don't recall it as too vertical. In that circumstance, you know, I'm the attending on, but I could be wrong. Cindy's closer in proximity to training. So I think go for it, try it. But usually it's not the same, like Emily was mentioning, Dr. Abawi, that it doesn't give you the same reach. If you pick the same horizontal, vertical, you're not really getting the full scope.
Why is, that seems counterintuitive to me. It's almost like if you're like chest tubing, if you're like through the skin, then through the lung, it's the same cut, you know?
You might be right. That makes sense to me about the chest tube.
Wow,
You're right.
she said
You're right
no.
about the chest tube.
So
So
vertical, she said.
But did we use that vertical before?
we did not.
So we want to try that
First one
vertical?
was
Yeah.
horizontal abdomen, vertical,
I thought that was the one I just said.
but now we're thinking vertical abdomen.
Well, what did you?
I thought I just.
At this time, the baby's
Oh,
almost dead.
vertical,
You know what the attending would have said? Can someone look it up and up to date already? That's what's happening already, but we can't do that. So go ahead, make your decision.
We are.
So is it vertical or horizontal?
I
Vertical
still,
or horizontal?
It's gonna make sense. So we did that horizontal.
But then aren't we changing
Oh,
two?
no,
We
horizontal.
didn't. Yeah, you have to, you only
Child,
change
this
that
is-
one is for, you're working with both vertical or both horizontal. So the question is, I think it's
Which one do you
vertical,
want to
vertical.
try?
Do vertical, vertical. We did?
Yeah. that
Do
was-
vertical,
That was the first
vertical.
correction that we made. And then she said that we switched up the wrong one.
Okay,
That's
so
it,
vertical, so it's
horizontal.
vertical, vertical. All right, let's
I
stop.
thought I just did that. All right.
No,
I think we stopped you. I don't think she.
Yeah.
Yeah, that was my bad. I'm
Okay.
sorry. I missed. I stopped.
All right, so we're gonna try and confirm that the fundus, and then we're gonna make a vertical incision from xiphoid to pubic symphysis, and then another vertical to the uterus. And then we're doing, delivered baby impact that.
You guys got it correct.
Ah!
Vertical. I love the conversations you guys were having. I am very much impressed at the conversations you guys were having. I love the teamwork. I love trying to figure it out. And people are like, well, no, I think because of this. That is the whole point of doing an escape room is to have these conversations and to try to figure it out. And you can pull from your senior residents' knowledge, right? They probably have a little bit more knowledge than you, or you maybe just read on this and you're like, no, I just read this. I know it's this, you know? So good discussion. This is probably the only time the instructor really does anything important, because once Once you've chosen the correct chronological order, the instructor will then tell the residents to flip over the cards. And then that will reveal a little phrase, key is under the table. The residents will look under the table and they will find a key. At that point, the room has been escaped, time stops, and they have officially escaped the room. So once they've gotten, that was probably the hardest one, and you guys got through that. So kudos to you guys. That was great.
So I think JC used an excellent analogy that I'm not going to forget.
Right.
Right. Going through the skin and then going through the intercostal muscles. Right.
Yep.
Ribs. So
I'm going to go through.
Cindy.
Oh, yes, of course.
Do you have, so they may get the right answer, but it's not the correct rationale. So do you expect them to go through their thought process to let them out?
So no, I don't expect them to go through their thought process, but at the end of the escape room, we have a debriefing session. Where we talk about, your rationale, why you did what you did and why certain questions were wrong. So we can go through this now. So the first case that we did was the GCS, which is our calculating our Coma Scale. And so it's based off 3 categories: your eye movements, your verbal response, and your motor response. So if you remember, our patient opened eyes to pain, that gave them a 2. Our patient was moaning, so it's incomprehensible sounds, that gave them a 2. And they had abnormal flexion, so they were posturing, and so that gave them a 3. I think what the residents struggle on with this is because each category has a different number of choices, and so 4, 5, and 6. And sometimes they kind of forget, well, I don't remember how much is in verbal, so I don't know what number this is, or they're speaking, but it doesn't really make sense. So is it inappropriate words or inappropriate sounds? And so then that kind of makes it a little bit harder to calculate a GCS. Again, the reason why it's important to calculate a GCS is because once we've calculated a GCS, we've gone through our primary exam. At this point, we've done a preliminary assessment. And we can either then at this point say, okay, this patient is really impaired as far as their level of consciousness, and I need to either take their airway, meaning I need to intubate them, or there's so much trauma or they're bleeding out that I need to bypass CAT scan and go straight to the OR. So calculating a GCS really kind of tells you how stable is my patient in this moment. And part of the GCS is doing your primary surveys, and that includes your airway, breathing, and circulation. So for example, if your patient comes in and they have a stab wound to their chest and they're moaning and their blood pressure is soft, are you going to put a tube down their throat to secure their airway? Are you going to take them to CAT scan? Are you going to put a tube down their throat, take them to CAT scan, or put a tube down their throat and take them to the OR, right? You would love to see, hey, they're stabbed in the chest. Where is this knife going right now? I'd love to get a CAT scan, but their blood pressure is dropping. They don't have time for that. What I probably have time to do is put a tube in their throat to secure their airway so I can now clear my head and say, I know I'm ventilating them. So I don't have to worry about right now, how much oxygen are they getting? And I go straight to the OR. I bypass CAT scan and I go straight to the OR because this patient is very unstable and they're likely to die on this table right now. And so that's why the primary survey is so important. And I think sometimes the residents, because trauma patients are traumatic, it's very scary, it's a lot of adrenaline, they can sometimes forget to do things in order. And that's why I included it here. Does that make sense to everyone? Okay. And so for our case that you guys beautifully mastered, resuscitative hysterotomy, AKA perimortem C-section, I thankfully have never had to do this. I've never had to perform it. I've been close a few times in residency. And The reason I say I thankfully have not had to is because it's traumatic on mom, but it's also traumatic to watch. I'm going to share a story that just happened last week, the last time I was at work. This woman was on the back of a motorcycle and they crashed. Unfortunately, the driver died on scene. Mom was rushed to the hospital. Mom was pregnant. And so when they got mom on to the table in the trauma bay, the nurse says, "I don't feel pulses." Okay. So now in this moment right here, you have to make a decision within 4 minutes. Okay, 4 minutes. So if mom loses pulses, the timer starts now. You have 4 minutes to decide, am I going to remove this baby? And then you have 1 minute to remove the baby. So by 4 minutes, you have to make your choice. And by minute 5, baby has to be out. There has been a few literature that say you can do it at 10 minutes, but by then, honestly, what are you really doing at this point? She's been down for so long. She hasn't had blood flow to her brain. You haven't perfused her uterus or the placenta or baby. So really, the school of thought is 4 minutes. Within 4 minutes, you need to have a scalpel in your hand and you need to be cutting. Okay. So this patient thankfully regained pulses. And then they whisked her up to the OR. But before they did that, because she lost pulses and they had a suspicion that she had some chest wall trauma. So she had what's called a pericardial effusion, meaning blood around her heart, which is not where it's supposed to be. So they actually did an ED thoracotomy, and we'll talk about that next. And so when they got mom into the OR, they made a very large vertical incision. The reason we make a large vertical incision, this is not meant to be pretty. This is not like a cosmetic thing. This is a traumatic patient. You're trying to assess the entire abdominal cavity. The uterus, depending on how old the child is, can be very large and starts to compress your organs, right? And so let me just go on here. So what is it? It's pretty much a C-section. So you take baby out of mom. You try to make them two separate things. Your primary goal, unfortunately, is not to save baby. Your primary goal is to save mom. Mom is your patient. If mom dies, baby dies, right? Mom is baby's blood supply. And also mom is your patient. And so the reason why we confirm that the uterus is at the umbilicus is partly twofold. Mainly because at this part in the pregnancy, the uterus is or the child is 24 weeks. The uterus is large enough that you can palpate it, meaning you can feel it. So because she now has a very large uterus, it's starting to compress on her IVC. Now, if someone goes into cardiac arrest, you want to keep circulating blood flow. You want to perfuse their major organs, their brain, their liver, their kidney. You want to make sure that you keep cycling that blood. If this very large uterus is now compressing the IVC is what brings blood back from your body to your heart. So you want to give mom the best chance. You want to decompress the IVC to optimize blood flow. And that's why you have to remove the uterus. Or excuse me, baby out of the uterus. You're not taking out the uterus. You just take out baby. The other thing is that as the mom goes further into her pregnancy and her uterus keeps growing, it pushes up her diaphragm. When you push up the diaphragm, your lungs can't expand as much. So by removing baby out of the uterus kind of comes down into the abdomen. The diaphragm drops, the lungs expand a little bit more, and you can oxygenate mom a little bit better. Now, the reason I say it's twofold is because at 24 weeks gestation, the fetus has a higher chance of surviving outside of mom. So if you have a pregnant woman who goes into cardiac arrest because of a traumatic event, and she's 12 weeks, and you don't feel that uterus, you don't need to do a hysterotomy because it's not large enough that it's compressing anything. And even if you took out baby, baby can't survive on its own. So you're not helping mom, you're not helping baby. If you do it for 24 weeks, or if the uterus is higher, in this case here, then you are helping mom, but you can also help baby. But just remember that that is not your primary focus. So in this case, you would call OB, you would call your peds, you would call your peds team, and you would hand baby over, and you would work on mom, because mom is your patient. So to run this back into my patient that I had last week, when they got her up to the OR, the general surgery resident later came down and told me, she said, we made the vertical incision, and as soon as I get into the abdomen, I see baby's face. So what happened is that when mom got into this car accident, her uterus ruptured. And so baby was freely floating in the abdomen. And so, you know, you do what you can. You try to save mom, you try to save baby. And these are rare procedures, but they're also very scary. And I can see on her face, like and so she made the cut and she saw baby's face and she froze. And she put the gauze over baby's face, and everybody's yelling at her, take it out. What are you doing? Take it out. But she's like, I couldn't do anything in that moment, because it was like, oh my God, I didn't know what to do. And so I like to go through these cases in a place that's very low pressure, where we can have these conversations and really talk about it. And so when you get into these moments where you have to perform these, these really traumatic procedures, you may freeze, but guess what? You know in the back of your mind, once you've calmed yourself down, I know what to do next. And that's, I think, my goal with this escape room, right? It's fun and you guys are laughing and having conversations. But when you leave here, the goal is that you know that I can perform this and I know how to, which is why it's so important, right? And so the next thing that happened, and so this is a quick video on just how to do it. This is done on a mannequin. So in case anyone's like a little uncomfortable, this is obviously not a real pregnant person. This is just a mannequin, okay? We're gonna play it here. We're gonna go start at 33. Can you guys see this YouTube screen? Okay, great. So, okay, I can't make it any bigger for some reason.
Okay, so I'm palpating abdomen. I clearly have a lady in cardiac arrest, palpably pregnant, right? Fundus well above the umbilicus. So I have my indication to do the procedure. And I'm going to start right at the top, up at the xiphoid. And I'm making a pretty big incision just vertically all the way down to the symphysis. I'm not a surgeon, right? Leon's a surgeon, but for me, I got to cut a few times to get through all these layers, especially for this lady. Okay, you can bluntly dissect as you need. Okay, and at this stage, you can have your assistant retract. I've got uterus here, bladder low down, making a smallish incision in my uterus. You get umbilical fluid splash out there. And I'm just putting my fingers in because I don't want to use scalpel the whole way and risk cutting baby. Using my fingers to protect as I'm opening up the uterus. And for me, I got to make a big incision, right? This is not cosmetic. Reaching in for baby's head. Baby is head down. That's nice. Oh my gosh. And sometimes you need some fundal pressure from the top there to help deliver baby. That's you, Brett. Your fundal pressure. The fundus is up the top. You got it, buddy. It's awesome. Right? Next step in baby, you're clamping the cord, 2 clamps, cut between them, right? Don't make the rookie mistake of cutting on either side. You're passing baby off to your neonatologist who's now doing the hard part, right? Tell me you're going to breastfeed, okay? You're back at baby. You still need to deliver placenta, right? Placenta is the part of this that consumes all the oxygen. And now, if you're a surgeon, you're making the layers nice. I'm not a surgeon, so I'm packing the abdomen with sterile towels. We use this because we have this. You're closing, and if I have a stapler, which I do not, I am stapling the skin shut. Comme ça.
Okay. Does anyone have any questions about what they've seen? Anything I can help clarify?
Yeah, I have a question. Why are you not stapling as you come, like why are you not stapling the uterus together before you staple the skin? And then why are you feeding gauze in to like a super unstable patient?
So if I was in a level 1 trauma center or maybe even a level 2 and I had OB that was ready for this patient, I wouldn't be closing the skin. I'd be going to the OR. Now, the only reason I can think that they're closing the skin is if they need to stabilize her in any other way, right? But I would be packing her abdomen. The reason you pack the abdomen is to try to control the bleeding. So the point of packing is you pack as much gauze as you can with the idea that the gauze or the towels is going to put pressure on whatever's bleeding and stop that bleeding or try and slow it down at least. And then I'm going to the OR. Now, you would staple if you were not at a level 1 trauma center or not like at least I'm a level 2 and she needed transportation. You needed to transport her. That would be the only indication in my head to close right now. Because if I'm in hospital and I have everyone I need, she's going to the OR straight. Okay?
Thank you. Yeah.
Yeah, no problem.
You know, I think the other thing, Cindy, do you want to comment on the concurrent resuscitation? What else is going on? Because this is just a model, but what else is going on as one person is working on the abdomen?
Right.
Because that also could be dissettling, right?
Yes. So thank you, because that's very important. CPR is still going on. You don't stop CPR to perform this, because if you stop CPR, you stop the blood flow of mine, and all that you're doing now is for nothing. So not only is this a traumatic procedure and you have to cut her from essentially chest down, imagine someone, just going like as hard as they can on this lady's chest and she's bouncing up and down. It's a very chaotic, high pressure, overwhelming environment. And so don't forget that everything else is still happening. So if mom is hypotensive, her blood pressure is low, you have your nurses who are, who are slamming blood into her. You have your people who are doing their chest compressions. If you use your ultrasound and you found that mom had a collapsed lung, right? You'd be putting in chest tubes. All of this would be happening at the same time. And so it's important for whoever is doing this to remain focused on what they're doing, because it's very easy to get distracted with all the noise in the trauma bay. It's very loud, right? Everyone's shouting, everyone needs things. And so when you're doing this procedure, it's very calm here, right? No one's doing CPR on mom, everyone's calm, they're making jokes, they're laughing, but in real life, this is a very chaotic type of environment, and it's already a stressful procedure. So thank you for bringing that up, Dr. Sanchez.
So the other thing is it's very easy for you to cut yourself.
Yes.
Right? And you have to worry about your own well-being and your team members. Mm-hmm. Scalpels are flying. And so when she was showing that she was cutting, it's actually safer to cut, right, than to use a scalpel, because at least then you're controlling it. And usually scissors above the hand are not going to cut you, right? You're going into a scalpel, you put your finger. So, those are the things you also want to be mindful for these, critically, but also invasive procedures that really you have to tell people to get away as you're doing it, because a lot of people get stuck and then you don't know the HIV status, the mom, or as bad hepatitis.
Yes.
Hepatitis C is probably more common than actually HIV. So, yeah.
Can I ask a question?
Yes.
Patient under anesthesia.
I can't hear you. I'm sorry.
So this is
Well,
do you have is this patient anesthetized when all of these things are going? I mean, I know that the oxygenation goes a little bit down. You don't want to give anesthesia, but this is very painful.
Yeah, well, she's dead, right? Her heart stopped. So technically, she's dead. So you don't really have to anesthetize because she's dead. I know it sounds a little bit morbid and a little bit harsh, but her heart's not beating. And so although you're trying to revive her, she's technically dead. Yeah. I know that sounds a little bit, like, oh yeah, she's dead, but sorry. Yeah.
I was just gonna ask who is the attending physician in this case? Is it an EM doc or is it OB?
Oh, so it's the EM doc because they're still in the ER. So whoever comes in the ER, they're under the emergency medicine attending. Once they become admitted, then they're under whoever service. But for trauma patients, they're technically still under the emergency medicine team, but trauma is also working on that patient as well. Yeah. And so for our last case, which the woman I told you about in my case last week, she actually had an ED thoracotomy. So essentially what this is it's done for trauma patients who come in with any kind of traumatic injury that has resulted in cardiac or lung injury, right? What we call it in the ER is cracking the chest, because that's really what you're doing. You make an incision on the left chest wall, you bring it laterally into the axilla near the armpit, and then you use rib spreaders and you spread the ribs to gain access into the heart. You're doing this because oftentimes you're trying to either plug a hole that's in the heart if the patient was stabbed or shot, or you're trying to temporize any bleeding around the heart or lungs. There are very specific indications for who you do this for, because doing this, although can be life-saving, this is also a very traumatic procedure. And so it doesn't have a very high rate of survival. Now, that could be due to the fact that usually patients who have this procedure done are already very sick to begin with. But I bolded the penetrating chest trauma because that has very clear cut and dry indications. If you have a person who was shot or stabbed or has any kind of penetrating wound into their chest and they present in cardiac arrest, but at some point, whether it was the paramedics or they lost pulses in the ER, they had signs of life. So either they had a pupillary reflex, they were moving, they were groaning, right? You don't do this for patients who have a penetrating chest trauma, who have been in cardiac arrest for longer than 15 minutes. There's just no use, and there's not a lot of benefit at that point. So there are very specific indications. If you have someone who has a penetrating chest trauma, who is hanging on to life, they're still alive, but barely, and they have an indication, meaning they have some kind of trauma to their heart and lungs, you can still perform this. For blunt chest trauma, it's a little bit more nuanced. There's some gray areas. So some people say, I don't do it for any blunt trauma. It's just not really an indication, right? Some people say, if I put in a chest tube and blood is pouring out of the chest tube, and there's 1.5 liters of chest tube upon immediately of blood upon immediately placing the tube, then I'll do it. There's a star there because it's really nuanced, and I haven't seen a lot of these done for blunt chest trauma. I've seen a total of 4 of these done, and they've all been for penetrating. So either they were shot, or they were stabbed, or there's some kind of chest trauma that happened that led to cardiac tamponade, which is really just blood pooling around the heart, making it hard for the heart to squeeze. And so for this patient, our pregnant lady, they did an ultrasound to look at her heart, and they found blood around her heart. And that's why, although she was a blunt trauma, that's why she had this done. I have a video here. It's unlike the other video, it's done on a cadaver. So if that's something that's going to make you uncomfortable or trigger you, I wanted to give you a warning in case you wanted to go to the bathroom. And then I can let you know when we've paused and you guys can rejoin. I just wanted to give you that space in case this is not something that you wanted to see. Okay. This video is linked because it's age restricted. It's going to take us to YouTube.
Resuscitative thoracotomy. The patient is placed in a supine position with the arm extended above the head. The patient is deliberately intubated in the right mainstem in order to collapse the left lung. The incision is made along the fifth rib from the sternum and extended to the posterior clavicular line.
In real life, it's done very quickly. It's just very quick incisions. It's not this
Blunt tip
slow.
scissors are used to cut into the intercostal muscle just over the fifth rib. The rib spreader is placed and the ribs are separated. The left upper lobe of the lung is moved in order to expose the pericardium. The phrenic nerve is identified.
You don't want to cut that because that controls your diaphragm.
A gentle incision is made above the phrenic nerve in order to expose the heart.
That stuff is
The rest of the
blood and
pericardium
blood clots.
can be spread manually. This maneuver will decompress the pericardial tamponade and provides access to the heart for repair and cardiac massage.
Oh wait, how do I go back to my? Okay, sorry. So I have unfortunately seen this done 4 times in my very short career as an EM provider. And every single time I've seen this, I have been like shocked. I just kind of stand there and I watch and I don't really, you know, I'm just like, I can't believe this is really happening and we're doing this. And all the patients I've seen this happen for, unfortunately, they didn't walk out of the ER. But I think that's largely because they were already pretty bad when they got here. And so this lady, when they did her thoracotomy, when she came into the ER, they had regained pulses. And then they brought her up to the OR. And I remember being told that her baby, unfortunately, it was too small. She was a larger woman, so it was hard to feel where her uterus was, but they knew that she was pregnant because they were told. But her baby was a little less than 20 weeks, so it wasn't going to survive on its own anyway. But they had regained pulses when they had brought her to the operating room, and I don't remember if she survived the operation or not. But again, you're still doing CPR the best that you can until you get into the heart, because then you can just use your hands and actually squeeze the heart there. And then you continue all your algorithms, right? So if you're doing ACLS, you continue with the epi, you continue everything you can. Once you get into the heart, if you find a hole, then you're usually going to throw a stitch in there as quick as you can, try to temporize the patient, regain pulses, and go up to the OR as quickly as possible. I unfortunately have never seen these patients make it that far to go up to the OR. Do you have any questions specifically about this procedure?
I have a question that's kind of related to it.
Mm-hmm.
It's a little bit off topic as well, but have you ever given internal heart massage? And what was that experience like?
So I have not on like during the procedure. I did it afterwards just to see what it would feel like. And so when that time come, I wouldn't be like so shocked by it. But not during the actual cardiac arrest. That's a good question. I wanted to leave some time to reflect and to ask more questions if you guys have it. I know what we just went through, was really heavy, and it's meant to provoke emotions and feelings. And so I want to create a space and time for you guys to ask me any questions or share how you're feeling about what we just went through.
I think this was great, and I would like to bring it to undergraduate years as well. In your groups, how many residents do you have? Like, how do you envision to do in a large room situation?
So we have 60 residents total spread throughout 3 years. Usually half of them come to conference in person. And so we broke them up into 5 groups of 6. And so there were only 6 residents per group, and we spread them over 5 of the classrooms in the medical school.
Okay, so so once you divide them, then among those 6 students, there is a balloon table,
Mm-hmm.
there is a basket table, and
Mm-hmm.
a final. So you
Right.
need 3 stations for each 6 students or residents, right?
Right. So the room has those 3 stations. They start at a balloon station, and they each have to stay in that group and progress throughout the room. And each room has the same 3 stations.
Okay, thank you.
Yeah.
Yeah, this was great. Thank you.
Thank you. Thank you guys so much. You guys were a very good audience. I'm very impressed. You guys had some really good conversations and really good questions.
I don't want to say something. I'll make it quick. Yeah, I just wanted to say that I really, really good presentation, and it's the first of its kind that I've seen. And I feel like people are constantly looking for ways to innovate learning. I've never seen this before.
Oh, awesome.
Yeah, it was awesome.
Makes me happy. Thank you. I love making learning fun. So my goal when I came to Houston and I came to this fellowship was, how can I make learning fun? How can I make, what I love, which is emergency medicine, like how can I make this engaging and interactive? And so when I was a resident, I played in one escape room and then I ran one. And I've been hooked since then. So I've been creating like a whole bunch of escape rooms for various topics. Like I did one for not rare procedures, like really common ones. And I did one for hematology. No one escaped that room except for one team because hematology is very hard. But it was very good.
Hi, Yes, I just have a quick question, because you made a distinction earlier on that when that patient came into the ER, mom is the patient, not the baby.
Right.
When do you decide that now the baby becomes the patient? Like, when does that change?
The
Or is
baby.
mom the patient the whole time?
So mom is your patient the whole time. So you would call your pediatric team, you would call your neonatal specialist, and the baby is their patient, but the baby is never your patient. Mom is your patient. So you work on mom and you try to save mom to the best of your ability.
Thank you.
You're welcome.
And then I have another question. I have a kind of general question about how you put this together. Could you walk us through the process of creating the scenarios for the escape room?
Oh yeah.
And did you beta test it? Did you just kind of like create an outline and see what happened? Or?
Great question. So the questions that I used are highly testable questions. So even though you probably won't see these procedures done or do them yourselves, they will be on your board exams and they will be on your in-training exams. And so that was that was kind of how I got my questions. And then how I created the rooms was honestly, sometimes it was just by chance. I'm like, oh, there's a balloon. Okay, well, if I have a lot of balloons and I pop a balloon, maybe that would be fun. And then also I kind of use my experience with playing in an escape room, like having clues hidden. And so that's how I got the idea of when you flip over the card, the clue is there. As far as the baiting testing, although this is not my first time creating an escape room, I've created 2 rooms in the past. This room is new. And I'm going to test it out with the residents. I have with a few of my colleagues, but not in large groups with the residents yet, not this specific room. And so our plan is to actually have a massive escape room day. So just 4 hours of having 5 escape rooms. The residents are just going to rotate through the escape rooms as a mass review. The way they used to do the review to their in-training, they used to have like a lecture. And I thought, well, that's really boring. So why would you have a lecture when you can make it fun, right? You can play an escape room. The last escape room I did with the hematology, we played a battleship. And I know that sounds weird because you're like, that sounds like a little strange. Like, how would you play battleship? But it worked. And they loved it and it was fun and they like learned something. And so that's, I think the larger project is to create multiple escape rooms and just have an escape room marathon and then have a competition to see which group escaped with the lowest time. And we're probably going to have a prize of some sort. Yeah. Good question.
Thank you.
You're welcome. You guys have been great. Thank you so much.